Hey, it's Medicosis Perfectionalis. Let's talk about anti-Parkinson drug. Part 1. Parkinson has what? Low dopamine but high acetylcholine. What are the symptoms? Everything is slow. Therefore, how do I treat Parkinson disease? Try to increase the dopamine or decrease the acetylcholine. Dopamine pathways. As you know, dopamine in the nigrostriatal pathway. Too much dopamine, you get too much movement. But too little dopamine, you're not moving. And this is Parkinson's disease. You're not moving due to loss of dopaminergic neurons in the substantia nigra pars compacta. Therefore, your nigrostriatal pathway is toast. The substantia nigra is called nigra because it normally appears black. But in Parkinson's disease, it appears pale because it's a disease. Dopamine in the mesocortical limbic pathway. This is not one pathway, two pathways. We have mesocortical and mesolimbic. Too much dopamine, psychosis, euphoria, hallucination. Too little dopamine, anhedonia. And that's why one of the side effects of levodopa that we give to treat Parkinson's is hallucinations, euphoria. Why is this? Because you're giving too much dopamine. Dopamine at the tuberoinfundibular pathway is antiprolactin. Therefore, if I have no dopamine, I have too much prolactin. If I have too much dopamine, I have no prolactin. And this is the best table ever. More dopamine functions. Dopamine will decrease food intake. Dopamine will trigger weight loss. Have you noticed that addicts are often thin? Yep, too much dopamine in the system. This is not the only reason. Another reason is that they do not eat. So, for example, alcoholics, they depend on the calories from the alcohol and they stop eating. Dopamine will decrease temperature control. Not good. Dopamine will stimulate your CTZ, which is chemotactic zone at the medulla, triggering nausea and vomiting. Dopamine can cause vasodilation peripherally. I have a video on YouTube called Dopamine and Dobutamine. Make sure to watch it. It's complicated. Where is the problem in Parkinson's? It's in the substantia nigra, which is in the midbrain, specifically substantia nigra pars compacta. Basal ganglia is part of the forebrain, so we say nigrostriatal pathway. Get it? Okay. Function of basal ganglia, motor function, voluntary movements, and adjusting posture. How about Parkinson's? The basal ganglia is toast, voluntary, everything is slow, and I cannot maintain my posture. I get postural instability. Basal ganglia include the striatum and the lentiform. Striatum includes putamen and caudate. Lentiform is putamen and globus pallidus. These are your lovely basal ganglia. Do not forget they interact with the substantia nigra. We call it the nigrostriatal pathway. The striatum is the putamen and the caudate. Caudate nucleus is damaged in Huntington's disease. Just keep in mind. Basal ganglia function, motor function. Don't forget the famous triad in Parkinson's disease. Tremor, rigidity, bradykinesia. I have resting tremor. Tremors during rest. When I move my hand, the tremor disappears. Awesome. But when I'm resting, the tremor reappears. Rigidity is described as cogwheel rigidity. Bradykinesia means brady, slow. Kinesia, kinetic, movement. So slow movement, everything is slow. Problem? Everything is slow. Management? Try to improve mobility. How? What's the problem? Dopamine is low, acetylcholine is high. So I'll try to increase your dopamine and decrease your acetylcholine. Pathology, degeneration of the dopaminergic neurons at the nigrostriatal pathway, the substantia nigra of the midbrain. Parkinson's disease is not the same as Parkinsonism. Parkinson's disease is the disease that we are talking about right now. Resting tremor, rigidity, retarded reflexes, no posture, all of this. Okay. Parkinsonism is secondary. This is not the actual genetic unknown idiopathic disease. We call it idiopathic because we are idiots and we cannot figure out the pathology. Parkinsonism is secondary, therefore we have figured out what's causing it. Drugs. Oh, so drugs can cause Parkinson-like symptoms. Yeah, how do you treat them? Stop the offending drug. Pesticides can cause it. How do you do it? Stop the pesticide. Infections. Treat the infection. Metabolic. Treat the metabolic disorder, etc., etc. But this is crazy. These are the diseases that can affect the nigrostriatal system. Parkinson's disease, the idiopathic, Parkinsonism, the one that we know the etiology of, genetic causes, and Parkinson plus or Parkinson mimics. This is not actual Parkinson disease. This is something like multiple system atrophy, Lewy body dementia, etc. All of these diseases are synucleinopathy. You see, a protein called alpha-synuclein. What is the cause of Parkinson's disease? No one knows. We have some theories. Don't forget the alpha-synuclein. Pathophysiology of the symptoms. The low dopamine is probably the cause of slow movement. So I'm not moving, bradykinesia. But the high acetylcholine is probably what's causing the rigidity. Because remember, normally dopamine increases movement. No dopamine, no movement. And normal acetylcholine increases plasticity. Too much rigidity. Remember, acetylcholine activated the neuromuscular junction at the N sub M receptor. So too much, of course, it can lead to muscle rigidity. Low dopamine can contribute to tremors, rigidity, bradykinesia, and postural instability. If you want to add acetylcholine, it is here. It contributes to the rigidity. Pathophysiology. Here is the postulated hypothesis for Parkinson's. Ubiquitin proteasome defect. Normally you have something called ubiquitin proteasome. What's the function? It catabolizes, it breaks down proteins. Fine. But in Parkinson's disease you have no ubiquitin proteasome. Oh, therefore you have decreased catabolism. Oh, therefore I have accumulation of these proteins. Yeah, but what is the name of these proteins? Oh, names. Alpha-synuclein, Lewy bodies. They bind to ubiquitin, causing neuronal dysfunction. And then the mitochondria is toast, and the rest is history, especially at the substantia nigra pars compacta. 5% of Parkinson cases are probably hereditary, and don't forget the alpha-synuclein. What are these Lewy bodies? Concentric eosinophilic cytoplasmic inclusions with peripheral halos and dense cores. Deposits in the neurons were substantia nigra pars compacta, astrocytes, oligodendrocytes. All of them stain alpha-synuclein. Most of them will stain for ubiquitin. They are horrible. Lewy bodies cause neuronal damage and death. Lewy bodies are not specific for Parkinson's. You can see Lewy bodies in many other diseases, including Lewy body dementia or dementia with Lewy bodies. Other sources will classify them differently. They will say, here is the topic, Lewy body dementias. And these Lewy body dementias are subdivided into Parkinson's disease, because it has Lewy bodies, and dementia with Lewy bodies, because it has Lewy bodies. Okay, Parkinson's disease, where's the problem? Is it central nervous system or peripheral nervous system? Central. Okay, in the central. Is it the brain or the spinal cord? It's in the brain. Okay, forebrain, midbrain, hindbrain. It's midbrain because it's the substantia nigra. Also, it's related to the forebrain because of the basal ganglia and the nigrostriatal, but let's keep it simple. We're exactly in the midbrain because last time I checked, it had tectum, tegmentum, and crus cerebri. It's part of the crus cerebri known as the substantia nigra, which pars compacta of the substantia nigra, of the midbrain, of the brain, of the central nervous system. Between the substantia nigra and the striatum is a pathway called nigrostriatal pathway. We need dopamine in this pathway. Too much dopamine, lots of movement. No dopamine, everything is slow. Here is a beautiful cross-section in the midbrain. Tectum behind, tegmentum in the middle, and the cerebral peduncle, which is in front. Where is the substantia nigra here? Nigra means black. It is this dark area. In Parkinson, it's pale, which is bad. This is the lovely cerebral aqueduct of Sylvius, which connects the third ventricle with the fourth ventricle. Surrounding the cerebral aqueduct, something called peri, around aqueductal gray matter or gray area. We have 5 types of dopamine receptors, D1, D2, D3, D4. Okay, we can classify them into 2 groups, D1-like and D2-like. D1-like include D1 and D5. They are GS coupled, S for stimulation. Okay, they will increase cyclic AMP, as you know. But D2-like include 2, 3, and 4, and they are GI, I for inhibitory. They will decrease cyclic AMP. Nigrostriatal pathway function, initiation of movement. Nigrostrial, from the substantia nigra to the striatum. Okay, where are the cell body of the neurons? It's in the substantia nigra. How about the axon and the terminus in the striatum? Cell body, substantia nigra output to the striatum. What's the striatum? Caudate and putamen. Where is the cell body? Substantia nigra. Okay, where is the tail or the axon knob or the axon terminalis? On the striatum. This is just one neuron. Beautiful, but we have 2 pathways. We have the direct pathway and the indirect pathway. What is the function of the direct pathway? To increase movement. What's the function of the indirect pathway? To decrease movement. Nigrostriatal. Let's go. Substantia nigra releases dopamine, acts on the D1-like receptors. They are GS, S for stimulation. Oh, too much move. Excellent, excellent. We have initiated the movement, mission accomplished. But indirect pathway, we release the same dopamine. It acts on different receptor producing a different function. It acts on D2-like receptors and they are GI, which means inhibitory. They will inhibit movement. Acetylcholine will also try to inhibit movement. That's why acetylcholine contribute to the rigidity. That's why we're trying to decrease acetylcholine in patients with Parkinson's. And here are all the medications that can treat Parkinson's disease. Let's start with the problem. Where's the problem? I have low dopamine. Okay. Why not give the patient dopamine into the patient blood? Because dopamine cannot cross the blood-brain barrier. So that's a failure. Do not do it. It's not going to be able to go from the bloodstream to the brain. It ain't going to happen, babe. So we got to circumvent it. Okay, got to be smart. Why don't we give L-Dopa? L-Dopa will go to the brain because it can cross the blood-brain barrier. Wonderful. Once inside the brain, it can be converted to dopamine thanks to the dopa decarboxylase enzyme. That is beautiful. Dopamine will solve the problem. Will L-Dopa resolve the patient's symptoms? The answer is yes. Will L-Dopa prevent Parkinson's disease progression? The answer is unfortunately no. But hey, medicosis, I have a problem. This L-Dopa can also be converted to dopamine here in the periphery, outside the brain, and this dopamine will not be able to enter. What a shame. So we can give another drug with the L-Dopa. It's called carbidopa. It inhibits the dopa decarboxylase only peripherally, not centrally. It does not touch the central dopa decarboxylase. It only touches the peripheral one in the peripheral circulation. Perfect. There is another name for the dopa decarboxylase. It's called aromatic amino acid decarboxylase. This is the aromatic amino acid. It's amino acid that has a lovely smell or odor. Wonderful. And it's a decarboxylase. The mnemonic is from dopa to dopamine by the decarboxylase. Any carboxylase enzyme requires vitamin B7, which is biotin. So if you want to be an excellent doctor, make sure that your Parkinson's patient is not biotin deficient. Otherwise, your dopa is going to go to waste. Levodopa, carbidopa, let's talk. It's a prodrug. Oh, really? Yeah, because L-Dopa is not very active. But once it becomes dopamine, now this is the active ingredient. What do we call this? A prodrug. Something inactive that is required to be activated in order to work. Does dopamine cross the blood-brain barrier? The answer is no. Does L-Dopa cross? The answer is yes. How does L-Dopa become dopamine? Dopa decarboxylase or aromatic amino acid decarboxylase. How can we inhibit this enzyme peripherally? Use carbidopa. Why not just give dopamine? It cannot cross the blood-brain barrier. As Parkinson's progresses, L-Dopa efficacy decreases. We try to give L-Dopa or save L-Dopa for the elderly patient. But if the patient is young, like 55 with Parkinson's, try other methods, not the L-Dopa carbidopa. Also, if the patient's Parkinson is very mild, do not go with L-Dopa. This is too much. Try something else. Side effects of L-Dopa carbidopa is something called on-off phenomenon. Now this is very confusing because it did not tell us on-off of what. On means there is dopamine, which is wonderful. Parkinson patient is so happy and moving and life is hunky-dory. But the off phenomenon, there is no dopamine. It's off. When there is no dopamine, everything is slow. I get dyskinesia. How do I mitigate and alleviate and ameliorate this on-off phenomenon? Atypical antipsychotics. How come? These will inhibit the D2 dopaminergic receptors and other mechanisms. Basically, they will try to balance the level of dopamine in the brain, preventing those abrupt fluctuations. L-Dopa carbidopa, too much dopamine, you get too much action, psychosis, hallucination, agitation. This is the mesocortical limbic pathway. Hypotension, edema, nausea, vomiting. On-off phenomenon. What's the cause? L-Dopa carbidopa. Why? Fluctuation of the dopamine level. When it's on, I'm moving because there is dopamine. When it's off, there is no dopamine. I have dyskinesia. Solution. Prescribe an atypical antipsychotic. So this concludes the L-Dopa carbidopa. L-Dopa will give you dopamine. Carbidopa will inhibit the peripheral aromatic amino acid decarboxylase, also known as the dopa decarboxylase. We'll discuss these in the next video. Parkinson plus syndrome, this is like tongue-in-cheek. It's not an actual disease. It's not an actual Parkinson's. It's similar to it. Similar in what? They are synucleopathies. Okay, give me an example of Parkinson plus. It's Alzheimer's and Lewy body. So you're trying to say that Alzheimer's and Lewy body can show me some tremor, rigidity, bradykinesia? Exactly. But these diseases usually have worse prognosis than Parkinson, and they respond poorly to anti-Parkinson's medications. What is the difference between Parkinson's and Shy-Drager syndrome? Parkinson is just Parkinson. Remember the triad. We have resting tremors, we have rigidity, we have bradykinesia. But in Shy-Drager syndrome or multiple system atrophy, we have the Parkinson symptoms plus autonomic problems. What do you mean by autonomic problems? How about orthostatic hypotension? That's an autonomic problem. How about urinary incontinence? That's a autonomic problem. This distinction is very important. Multiple system atrophy, quick review. It's a progressive idiopathic whatever. It begins in adulthood. Parkinson plus autonomic symptoms, orthostatic hypotension, urinary problems, cerebellar problems, pyramidal problems, and it still has the alpha-synuclein. The atrophy is everywhere. That's why we call it multiple system atrophy. Everything is toast. Good luck if your family doctor can diagnose this. Good luck. Lewy body dementia, what's going on? It's a dementia and some Parkinson's symptoms. So I lost my memory. And I have rigidity, resting tremor, bradykinesia, etc. What would you see in the brain? Lewy bodies. They are concentric eosinophilic cytoplasmic inclusions that stain for alpha-synuclein. See you in the next video, part 2.